My dear friends, ladies and gentlemen, Assalamu alaikum. This is Dr. Muhammad Gouda from Egypt, and this is the second video of our series of 100 Ophthalmology Secrets. I would like to thank you for watching my first video, and I would like you to encourage me to complete this series by liking, sharing, and subscribing to my channel. Let's go. A good selection of your patient is the key for a successful surgery, especially in refractive surgeries. Avoid skeptics, people with unrealistic expectations, psychics, and arrogant. Always under-promise and over-deliver. This is a personal advice. It's not written in a book, and you will learn by time about the psychics of the patient. Number 22. Don't use 300 micron residual stromal bed in refractive surgery. It is now replaced with percentage of tissue altered. Percentage of tissue altered is the flap thickness plus ablation depth. This PTA should not exceed 40% of central corneal thickness. Example, you have a central corneal thickness of 500 microns, so its PTA is 200 micron. In this example, flap thickness plus ablation depth shouldn't exceed 200 micron. So if I know my intended flap thickness, how to know the ablation depth? To calculate ablation depth, you have two methods. The accurate method, using the laser machine computer or simulator, or the quick method if you are in your office and you want a rough estimate about the ablation of this patient. I use Munnerlyn Formula. Munnerlyn is an American optical engineer. He designed the first laser correction machine, and he's the founder of Vizix, one of the largest laser vision correction manufacturers. Munnerlyn Formula states that ablation depth in microns equals refraction divided by 3 multiplied by square optical zone. I know this is a lot to process, so we have an example of -6 diopters patient with intended optical zone of 6 millimeters. So ablation depth is 6 divided by 3 multiplied by 36, which is the square optical zone. So the ablation depth in this patient is about 72 microns. You need to know that this is a theoretical formula and it is not 100 accurate. Suspect thyroid-related ophthalmopathy in patient with non-specific redness, inflammation of their eyes, even if there is not a history of systemic thyroid eye disease. Listen to your eyes, it is not just allergies. The most common cause of unilateral or bilateral proptosis is thyroid eye disease, Graves' disease. In children, the most common cause of unilateral proptosis is cellulitis, while in adults it's thyroid. A patient with recurrent chalazion in the same spot must be evaluated for sebaceous cell carcinoma. According to New York Eye Cancer Center, any conjunctivitis or chalazion that is not getting better after 3 months of observation should be biopsied. Look at this photo. A sebaceous cell carcinoma is suspected due to evidence of eyelash loss and formation of a yellow nodule. Once diagnosis is made, a metastatic survey is warranted. Sebaceous cell carcinoma can spread to regional lymph nodes, as well as to lung, brain, liver, and bone. Number 28. Dacryocystitis should be treated emergently to avoid cellulitis or intracranial spread. Number 29. CT is superior to MRI in most cases of orbital disease due to better bone tissue delineation, and here is a normal CT orbit. Number 30. A child with rapidly progressive proptosis, inferior displacement of globe, and upper eyelid edema should have immediate neuroimaging to rule out rhabdomyosarcoma. Remember, rhabdomyosarcoma is a tumor of soft tissue, not from skeletal muscle itself. All patients with anterior uveitis must have a dilated exam to exclude posterior segment disease. Number 32. Early sign of chloroquine retinopathy is perifoveal RBE changes. Here is the Humphrey field for this patient. Notice the perifoveal arcuate scotomus. And remember that bullseye maculopathy may take years to happen. Number 33. Retinoblastoma is the leading eye cancer in its children. Over 95% of retinoblastoma children in USA and developed countries can survive due to early detection and proper management. Most cases with unilateral retinoblastomas are treated with enucleation. Most children with bilateral retinoblastoma are treated with chemoreduction. The leading cause of legal blindness in Western countries is age-related macular degeneration. Predisposing risk factors include increased age, smoking, and family history. The most common cause of vision loss from diabetic retinopathy is macular edema. The globe is most likely to rupture at the limbus underneath rectus muscle or at previous surgical site. Most cases with thyroid-related ophthalmopathy will not need surgical intervention and it will burn out with time. Squamous cell carcinoma may metastasize systemically. Smoking is a controllable risk factor in thyroid eye disease and age-related macular degeneration. Finally, any patient suspected with giant cell arteritis should immediately start intravenous steroid to prevent involvement of the other eye, even if temporal eye biopsy cannot be done. Thanks a lot for watching. I hope to subscribe to my channel. I hope to share this video and I hope to listen a feedback from you. Thanks a lot. Dr. Muhammad Gouda. Bye bye.